This presentation is entitled Pharmacology and Toxicology: Principles, Applications, and Limitations. I will now pass it over to Dr. Lewis Nelson to begin our presentation.
Good morning. I'm Lewis Nelson, and today we're going to talk about the very important topic of pharmacology and toxicology as it applies to addiction medicine and addiction medicine practice. I have no financial disclosures, but I do want to remind everybody that if there are any questions during this talk, please just enter them in the chat, and I'll try to answer them as best I can in real time. Briefly, just to think about what we're going to talk about today, we're going to focus a lot on how drugs and medications interact with the body in terms of how they move through the body, which is the description of pharmacokinetics, and how they interact with the body, which is the description of pharmacodynamics. We'll talk at the end a little bit about some of the drug testing techniques that we utilize. It's going to be a fairly superficial discussion given the needs of this course, but there's a lot more that we're not going to be able to cover when it comes to that specifically. And I'll give you some resources as we go through that to make sure you can follow up. So it's really important to understand that addiction medicine is pharmacology, and pharmacology is addiction medicine. I mean, in order for a drug to have an effect on your brain, it has to get in. And the blood-brain barrier was made to be an effective barrier to drug entry. Right? We know that some of the principles are very consistent across substances, such as the fact that in order for a drug to be euphoric, the rate of rise of that drug in the brain has to be fairly quick. If it dribbles in, it's not going to have that same effect. A great example is morphine and heroin, which we'll talk about a little bit later. But morphine enters the brain very slowly, and it's a good pain medication. It doesn't rise quickly enough as heroin does to really cause the euphoria that we think about when people are out looking to use a substance for the pleasurable effects that it causes. And of course, dependence is somewhat of a different concept, but equally as important in the practice of addiction medicine, really relies on the duration of exposure, right? A single exposure or short exposure is not going to leave you with an opioid dependence or withdrawal syndrome when you discontinue or reduce the dose of medication. But it's got to be an exposure over a long period of time at a reasonably high dose. So these concepts we'll come back to, and they're very important. So I mentioned PK and PD, easier than saying those very long terms. You can see a little bit of a conceptualization of what we're going to talk about when we talk about the orange versus the blue. And we'll cover all of these topics. And of course, if you have any questions, please just enter them again into the chat. Simply stated, dose response is the basis of how medications work. And pretty much everything we use in all of medicine, whether it's in substance use or in clinical medicine itself, the more you give, the more you get. And these are just two depictions of the same data, but it shows that as the dose goes up, the response increases. The response could be anything, as I put at the bottom. If it's a medication to raise or lower your blood pressure, the more you give, the more your blood pressure go up or down. Right? When it comes to substance use, of course, we think much more about euphoria. And there you can imagine that the more of any substance you take, the more euphoric it's going to be. And of course, at the same level, the more you take, the more likely you are to have an adverse outcome, such as death. Not all dose response curves are linear or as predictable as that one is. And there are some that have U or J-shaped dose response curves. And just a quick example of those, for example, would be a vitamin. At too low a dose, you start to have adverse effects from not having enough vitamin. As you increase the dose, you get to where you need to be. And as the dose goes up, there's actually toxicity associated with it. Right. The same could be said to some extent about ethanol. If you believe that low doses of ethanol actually might be healthful, and obviously there's a lot of questions about that. Another example would be oxygen or water. Without any of those, you're going to die, and each of those is toxic at higher doses. Potency is really important, and I think people make a lot of, I want to say, mistakes with this term, because we like to say a lot of things are potent, but I think we have to really call out what it means. In order to say something's potent, you have to know how many milligrams per kilogram or whatever unit you're using of that agent does it take to have a given effect. So just in your brain, as I'm talking, rank order the potency of these agents at causing death. I'll tell you, a lot of people are often surprised when I show them the answers, but ethanol is particularly non-potent. I mean, it takes grams per kilogram to be lethal, whereas nicotine and morphine are approximately the same potency at causing death. And of course, fentanyl we know as being fairly potent, and botulinum being exceptionally potent, probably the most potent toxin we know of, at least that we interact with on any regular basis, where it's literally high picograms, low nanograms per kilogram to elicit death. But don't confuse potency with clinical effect, right? So if I were to ask you which of these two products has more potent THC, the weed that some people used in the 1980s, maybe they were in college or high school or grad school, versus what people sell today. Well, it's a bit of a trick question because the THC, the tetrahydrocannabinol, has the same potency, but people often say that 2020 weed is more potent than 1980s weed. Right. And it's true that there's more drug per milligram or per gram of product, but the THC itself is exactly the same. Right. So don't confuse potency with its concentration, because we really should say that the concentration of THC is higher today than it was 40 years ago. But potency, despite all the discussion about it, has very little influence on anything. It probably doesn't really matter because if you look at every one of these drugs listed on this graphic, they can all kill you if you take enough, right? Obviously, it takes a lot less physical amount of carfentanil to kill you than it does tramadol to kill you because it's much more potent. But all of these can be lethal, right? And this is the basis of toxicology, by the way. And I always like to remind people, dose makes the poison. And you could read what Paracelsus said about it. But basically, everything is safe if you take a small enough dose, and everything is dangerous if you take too much. Right? And I like this as an example because this is a graphic you'll find on the internet. It'll just show you the lethal amounts of these three drugs. We know that fentanyl is about 50 times more potent than heroin, and we know that carfentanil is about 100-fold more potent than fentanyl is. But all of them are safe if you take the right doses, as this graphic shows. Of course, you can mix them and still have safe doses as long as you reduce the dose of one as you increase the dose of the other. If you take a little bit too much of each, you get into the danger range. And if you take too much of any of them, combination or individually, you will die, right? So it's all a matter of dose makes the poison. So I want to go through a whole bunch of these pharmacokinetic and pharmacodynamic issues as we kind of apply them to clinical medicine, both understanding why people use substances and how we look at those patients when they come in and how we follow them and treat them. So the route of administration, I mean, I think everybody knows this. This is not particularly new information for most people, but remember that oral medications are often susceptible to extensive first-pass hepatic metabolism, which is why so many medications like naloxone, for example, can't be given orally, or buprenorphine, for that matter, is not given orally. All these other routes that are parenteral, whether it's IV, intranasal, intramuscular, buccal, inhalational, you can read those, all bypass first pass through the liver. So they will eventually get to the liver, of course, but their first pass isn't through the liver to be eliminated. You can read down the list. I want to remind people that intranasal is of particular interest to us nowadays, particularly with naloxone, but intranasal medications, or drugs for that matter, may be able to actually access through what's now called nose-to-brain transmission, right up through the cribriform plate, through the olfactory nerves, direct access into the CNS. And that would make some sense because we think, and I believe, that naloxone works more quickly than it should when you give it intranasally. And that's not, it may be a little bit that the nasal mucosa is a great absorptive surface, but it might also be because of this nose-to-brain transmission. Bioavailability is the amount of unchanged drug that reaches the systemic circulation after administration. So the route is really important. If you give it IV, it's 100% bioavailable. It has to get in. There's no alternative. It's not getting stuck to the sides of the vessel as you're injecting it. But every other route of administration has a reduced bioavailability. And you sort of have to go by each drug. Some drugs are pretty well absorbed orally. They don't undergo first-pass hepatic metabolism, and they get absorbed through the stomach or the duodenum. Some drugs given intramuscularly are exceptionally well absorbed as well. Right? And we're going to talk about a few of these other issues as we go forward, but recognize that bioavailability is a critical issue when we talk about some of the drugs we use today, like buprenorphine or naloxone. Right, and I just show you some of the bioavailabilities. We dose things understanding their bioavailability limitation. So we'll give more of a drug by an unfavorable route than we would if we gave it by a favorable route. Just as an example, an 8 milligram buprenorphine dose given under the tongue is probably equivalent to about 0.3 milligrams given IV. And we use IV buprenorphine in our clinical practice. What ultimately matters, as I've sort of alluded to, is the area under the curve. That's the total amount of drug absorbed after administration. So if you add up all of the amount of drug under each of those lines, they should be equivalent if bioavailability were equivalent. Right? Of course, you increase the dose in order to make sure that you get the right amount of drug into the body, but it's the area under the curve that accounts for the total concentration of drug absorbed after administration over time. Just as an example of this, everybody remembers OxyContin. It may not be available excuse me, anymore, but there are generic extended release medications and OxyContin equivalents and other drugs that undergo controlled release. When this drug was first released, or this medication was first released, remember it was crushable, right? So that 80 milligram tablet, which was meant to release over 12 hours, could be crushed in that entire 80 milligrams of oxycodone, rather than being released over 12 hours, was released immediately. Right? That gave you, even though it was oral and the bioavailability is the same, it gave you a very large bolus dose all at once. The area under the curves of those drugs would be the same, right? But because the release mechanism was different, the amount absorbed quickly was very high, as opposed to over a long period of time, leading to high blood levels and, of course, the euphoria, which was sought after, but also the risk of overdose and death. And that's exactly what happened. And in fact, in the package information in the advertisements, it actually gave you this information, which was always concerning to us. Of course, the FDA required the medication to be reformulated. It went from OC, OxyContin, to OP, OxyContin, which was the reformulated version, which was no longer crushable. It was called abuse deterrent, and it was no longer microwavable, and the drug could no longer be extracted from that tablet. It led to a whole host of other issues, which we're not going to talk about here. Distribution through the body. Well, we talked a little bit about first-pass metabolism, how we avoid that by choosing a pharmacokinetically favorable route, but basically everything you put in your stomach and gets absorbed or through your duodenum winds up in the liver. Right? We bypass that by using intranasal drugs or by using sublingual drugs, and that's one of the mechanisms, and many of the other routes that we've talked about. Remember, you learned in school at one point that it takes about 5 half-lives to get to a steady state. But the half-lives of drugs all differ. So not all drugs get to steady state in the same amount of time. They all do take 5 half-lives, right? And this is one of the tricky parts about using methadone. In part, its half-life is very variable, as you can see, 12 to 36 hours. So if you're a rapid metabolizer, you will get to a half-life much more quick. You'll get to a steady state much more quickly. But if you start to add doses too close together on somebody who's a slow metabolizer, those doses will accumulate and they'll stack, and people will wind up having respiratory depression and essentially having an opioid overdose. So it becomes tricky, as many of you who work in methadone clinics understand, that the induction period, the initiation period for methadone is often a difficult time. It's important to remember that medications and drugs, for the most part, are not actively absorbed. They enter our brain through diffusion across the blood-brain barrier, right? And you can sort of see that here. They get into the body and they get into the brain through passive diffusion. There are a few drugs that we use. There's some medications, but from a drug use perspective, there are a few that get actively uptaken into the brain through an organic anion transporter. But there are some that are kicked out of the brain by a transport mechanism called P-glycoprotein. It's a very effective mechanism. It's fairly nonspecific, and it ejects from the brain many of the medications and drugs that we use. A great example of how street pharmacologists have figured this out is to use drugs that inhibit P-glycoprotein, some of the PPIs, for example, when they use a drug like loperamide, which is an Imodium, right? Loperamide is an opioid that would, if it got into your brain and stayed there, would work like an opioid, and you get euphoric from it. The problem is that the P-glycoprotein is so effective at eliminating it that it's not a useful drug to use to get high. But by taking it with a P-glycoprotein inhibitor, as Reddit and other drug forums like Blue Light or all of those we'll have in the discussion boards, examples of people who tell one another what they did in order to use loperamide or various other drugs as an opioid to use to get euphoric. Lipophilicity is important. Remember, the blood-brain barrier, in fact, the entire brain is really lipid. So things that are lipophilic are able to get into and across the blood-brain barrier very easily. So lipophilic drugs tend to be more rewarding. More rewarding drugs tend to carry a higher abuse liability, meaning used to get high. Not using it in a pejorative term way, just the idea that these are the drugs that are very liable to be misused. Just a nice example here would be taking a drug like codeine compared to morphine. After being injected into the tail of a mouse, you could see the amount of it that gets into the brain on the first pass through the cerebral circulation. Very little morphine. But codeine is methylmorphine. By putting the methyl group on that, it makes it more lipophilic. Heroin, of course, is diacetylmorphine, so even more lipophilicity and more increased brain uptake. And we're going to come back and talk about this in a bit, but it's very important. You'll see methadone there as well, which is a fairly lipophilic drug and also very rapidly entering the brain. Now, because methadone is taken orally, there's a slow absorptive phase from the stomach or the swell bowel, which limits its use to get high, but it does have a euphoric potential. And of course, fentanyl, being super lipophilic, much more so than any of these others, is associated with a high reward and high liability for misuse. And the metric that we use to determine how lipophilic something is called the log P. There are other modeling systems. The octanol water coefficient would be another example. But just here you can see just how lipophilic some of these are. Remember, this is a log scale, so it's 10. Each point is a 10-fold increase. And you can see how you pretty much double when you go from morphine to heroin, but then you add on another 2-fold increase when you go to fentanyl. It shouldn't surprise people that buprenorphine is lipophilic as well, because it does get into the brain very effectively. It's not particularly euphoric, as everybody knows, because it's not a full opioid agonist, and it's not a rate limitation. It's an agonism limitation, which we'll talk a little bit about. Some of the other opioids, like oxycodone, is more lipophilic, and one of the reasons that it's chosen by people among the prescription opioids as the one they most favor, even more so than hydrocodone. Another example here would be the comparison between cocaine salt, which is we call cocaine, and cocaine base, which we call crack. You could see that the cocaine salt is exactly that. It's a charged product. Charged products don't enter lipid membranes very well and are not very good at getting you high. Obviously, it gets in, of course, because it does get you high after you use it, but not as well as the cocaine base, or the smokable so-called crack. Right? And here in a nice example, you can see on the left, you can see that the plasma levels of the smoked and the IV are quite different after using an equivalent amount. But the subjective effect of the two on the right are nearly equivalent. And that's simply because the IV formulation is a charged product, doesn't get into the brain very well. The smoked product is uncharged, right? That's alkaloidal cocaine, and it does get in very well. And again, there's a lot of politics and philosophy and other things associated with these two drugs, but from a pharmacological perspective, I think it's important to understand the very specifics of why those things are the way they are. The half-life is obviously the amount of time it takes for a drug level to fall by half. And I think everybody recognizes that. But what you probably don't recognize is that there are multiple half-lives. If you think about it, a drug gets in your body and then into the brain, and that's called the distribution half-life. And then it goes from the brain back into the body, and that's called a redistribution half-life. And then it's from the body, it could go somewhere else into a third compartment, or it could leave the body altogether, which is ultimately called the elimination half-life. So there's a lot of different half-lives. And sometimes that gets us a little bit wrapped up in knots because we try to talk about half-life as if it's the same thing as clinical effect. And they're not the same. A drug can last a long time in your body, but have no clinical effect because it's no longer in the brain. Right? And we talk about those in terms such as context sensitive or apparent half-life. And I think it's really important to understand how half-lives matter. Right? Fentanyl's a very short-lived drug, but it's got a very long terminal elimination half-life, right? Because it leaves the brain quickly, so it's short-lived, but then it redistributes into the body fat, and it stays there for a long time. But the levels left in the blood, i.e. left in the brain, are very low. So it's got no more clinical effect, even though it's still present in the body. We think a lot about biotransformation as a mechanism to eliminate medications and drugs. And here's just a good example using ethanol. We recognize that there's multiple different ways ethanol could be eliminated, one of which is using alkyl dehydrogenase, and another is by using the mixed ethanol oxidizing system, or MEOS, which is really the cytochrome system, the 2E1 system to eliminate it. And all of those are active in the elimination of alcohol, right? It's important to recognize that they're all a little bit different. ADH varies among people, among genders, among races and ethnicities, and it explains some of the facts that, some of the issues that we see, for example, with what's so-called quote unquote Asian flush, right? Because the alcohol is rapidly metabolized to acetaldehyde, which is then rapidly eliminated by aldehyde dehydrogenase. In certain populations, they have an overactive ADH or an underactive aldehyde dehydrogenase, leading to a buildup of acetaldehyde, leading to what's this so-called flush syndrome that people have. It is not limited to Asians, but that is the name of the syndrome. Sometimes medications could be activated through biotransformation. Codeine is a great example because codeine itself is a very poor analgesic. In fact, in populations that are deficient in 2D6, which is about 7% of the US population, codeine does not work, period. Right? It needs to be metabolized, demethylated to morphine. So codeine is a prodrug that has to be metabolized before it's effective. Lisdexamphetamine is another example of a prodrug used for syndromes such as attention deficit disorder. But what's, I think, really interesting, I say it's a fun pharma fact, is that heroin itself is actually not an effective agent, just like codeine is not. Neither codeine nor heroin bind to the opioid receptor in the brain, but heroin serves as a carrier molecule because it is lipophilic and it crosses the blood-brain barrier quickly. In the brain, it's deacetylated by cholinesterase very quickly, super quickly, to morphine, and morphine actually binds to the receptor. So when you're using heroin and getting high, you're actually getting morphine toxic, not heroin toxic. If I injected morphine directly into your brain, it would appear such as heroin, but obviously that's not an effective way to use a drug or a medication. There's lots of information about biotransformation. I don't want to spend time on this, but I'll let you look at this on your own. But remember that there's a million different polymorphisms and differences in, as I mentioned earlier, races and sexes and other groups as to how they metabolize medications, which is a whole field of science of personalized medicine unto itself. For our purposes, I think there's some role here to understand it, and we're at the infancy of understanding how buprenorphine and methadone and some of these other medications are affected by those varying demographic characteristics. Let's talk a little bit about receptor pharmacology. We know the terms full agonist, partial agonist, and antagonist. I think the concept makes sense to everybody. Graphically, you can see it on the right. A full agonist has a pretty standard dose response curve. As the dose goes up, the response gets greater until it's such a high dose that the response is maximal and it can't work anymore, right? Often that might be death when it's a drug like fentanyl. Buprenorphine is a partial agonist, essentially has a ceiling effect, a dose, a physiologically acceptable dose at which the drug stops having any more efficacy. Right, so you can see that there's a plateau halfway up for buprenorphine, and that's why it's called a partial agonist. An antagonist, of course, has an effect on the receptor of naught, of zero. It does nothing to the receptor but blocks it. In general, if I give you an antagonist and you have no agonist present, it does nothing. So naloxone given to somebody who's not using an opioid has no effect. In fact, in the past, people have studied naloxone for varying reasons, such as spinal cord injury, because there was a belief that endogenous opioids were problematic in patients with spinal cord injury, and by blocking them at the receptor level in the spine, it would actually improve outcomes. People did not have problems getting milligram or literally near gram doses of naloxone if they were not already dependent on an opioid. Now, an inverse agonist is different because that's an agent that binds to the receptor and has the opposite effect. In a way, it would be like me giving you an inverse agonist at the opioid receptor and you getting pain, right? Or you getting agitated. We don't have that in this case, but there are inverse agonists that we use in other situations, or drugs that have inverse agonist effects, I would say. I don't think we really use any specifically clinically. But that's called receptor efficacy. It's what it does to the receptor. It's very different than receptor affinity, which is so-called how tightly a medication or drug binds to a receptor, right? You can see some examples here of receptor affinities, but I want really for people to understand that there's a lot of mismessaging about affinity. And you'll see stuff like this news clip that says, if you use fentanyl, naloxone doesn't work. And in fact, naloxone works fine, right? The affinity for naloxone is much higher, or higher enough than the affinity of fentanyl, that it will, quote unquote, knock the fentanyl off the receptor, right? Now, if I give you so much fentanyl, because it's a competitive antagonism, that the naloxone just can't compete, it will appear not to work. But at the receptor level, it does knock it off. The only drug that really can't be knocked off the receptor by naloxone is buprenorphine, paradoxically. But at the same time, buprenorphine will itself knock everything off the receptor because its affinity is substantially higher. Right? And you can see some of these drugs have fairly low affinity. Right? Look, heroin is substantially lower affinity than naloxone. Remember here, affinity, and I should just state this, that the lower the number, the higher the affinity. Right? These are the KIs, which means that this is the amount of drug it takes to occupy 50% of the receptor. Right? And so the lower the amount that it takes to occupy the receptor, the higher the affinity is. But the reason behind affinity is really important to understand. So we know that receptor occupation, in other words, sitting on that receptor, is a measure of affinity. Activating the receptor is a measure of efficacy. And you can see how those two together create a response. But what's actually going on here is that receptor, that drug, is actually not binding and clamping onto that receptor and not letting go. It's actually on, off, all the time, probably thousands of times a second, right? So when we talk about a drug that has higher affinity, it doesn't mean it's glued to the receptor. It means it's on a little bit more than it's off, right? So you could still be off for a while and slip another drug in there. So that's how naloxone is able to knock all of these things off, even if their affinities are relatively equal. If I give you enough naloxone, just by mass effect, it should be able to displace all medications, even buprenorphine at some level. But buprenorphine has an affinity of around 5-fold higher than naloxone does, which also makes you question that whole idea of bup-naloxone combinations, if that, and what effect that would have, because many claim that the naloxone causes them to feel lousy, when in reality the naloxone probably can't knock the buprenorphine off the receptor. Tolerance is the reduction in response after a drug is administered repeatedly. It looks graphically like a dose response curve shift to the right. And you can see that after using it, those lines splay a little bit, and it takes a higher dose of a medication, of morphine in this case, to have the same effect, right? And that is basically what tolerance looks like. Tolerance, though, is differentiatable, right? In other words, tolerance to analgesia may occur, while tolerance to the GI effects of an opioid or the respiratory depressant effects may not. And you can see that the line on the right doesn't splay over time with increased use, which is a bit concerning because the analgesic effects cause tolerance, but the respiratory depressant effects don't. Right? This leads to the problem with a paradox of differential tolerance, right? When you start out, the respiratory depressant effects and the analgesic effects parallel one another, but over time, of course, what happens is they cross, right? And there's a point at which you will have enough, you will be taking enough opioid for analgesic effects that you cross the respiratory depressant threshold, which is why even people that take therapeutic doses of an opioid for well-meaning purposes still die of respiratory depression. They don't have to overdose. They could be taking what they believe is a therapeutic dose. The tolerance to analgesia develops rapidly. The tolerance to respiratory depression is slow. And the tolerance to the GI effects is essentially non-existent. Pharmacokinetic tolerance is what I talked about a little bit earlier when it comes to the liver, the hepatic metabolism of alcohol. Even though ADH, alcohol dehydrogenase, is not inducible, the cytochrome system, the MEOS, is. So you can rev up 2E1 so that you can metabolize alcohol more quickly. Right? This explains why, if you looked at the elimination rate of alcohol, it's much faster in chronic heavy users than it is in occasional or social drinkers, because they've had a lot of time to induce the metabolism of 2E1. That takes weeks or at least days to occur. It's not going to occur after a weekend of social alcohol use. And then there's the pharmacodynamics of tolerance. And here what you're looking at are changes in how the receptors are affected by alcohol. Right? Essentially, I'm just using alcohol as an example. This could be opioids as well, or anything for that matter. But at baseline, you have normally functioning receptors, both the GABA on the left and the NMDA receptor on the right. With light use, you get some enhanced inhibition and some blocked excitation, and you feel good, and that's euphoria and intoxication. Over time, you develop tolerance, where you desensitize the GABA receptor by changing some of the components of that receptor, and you increase the number of excitatory neurotransmitter receptors, the NMDA receptors, right, which bind to glutamate. You're now at a new baseline, right? As long as you drink, you're fine, but when you stop drinking, you lose the inhibition, and you have uncontrolled excitatory neurotransmission, and you have withdrawal, right? And that's exactly how withdrawal from alcohol goes. You could say the same about opioids and other drugs that cause tolerance. Remember, cocaine and amphetamines don't induce this degree of tolerance and are not really associated with a classical withdrawal syndrome. Other quick examples would be something like the Mellanby effect, which I think we see regularly. It basically means that as you're drinking and getting intoxicated, you're more intoxicated than you are as you're sobering up after the alcohol use period. Right? So you're less intoxicated on the descending, at least when you measure it clinically, and I think many people believe this to be true, as you sort of stop drinking for the night, right? And that's called the Mellanby effect. You'll see something we call tachyphylaxis, which is the rapid development of tolerance, particularly with some of the high potency serotonin receptor agonist hallucinogens like psilocybin and LSD, where if you use it now, you can't use it again tomorrow. You might have to wait 3 or 4 days before it's going to work again, unless you take an exceptionally high dose. In this case, you have to take 290% of what you took the first time, right? So that's a substantial commitment in order to be able to do that. And people have asked a lot about how do you overcome this, and the answer is you just can't. You have to let the receptors reset themselves. But we also see benzodiazepine resistance in people who use alcohol. who are in alcohol withdrawal, which occurs early on. Benzodiazepines work really well to treat alcohol. But as you give more and more and more, you actually develop tolerance to the benzodiazepine itself through a mechanism that's unrelated to the alcohol-related dependence through the benzodiazepine receptors. And if you give it IV, you actually see tachyphylaxis, and tachyphylaxis means the rapid development of tolerance. So just like you see with the psilocybin, you'll see that with IV benzodiazepines as well, which is why PO medications, if the patient can tolerate those, is a much better option for people in alcohol withdrawal. Conditioned tolerance, of course, just means colloquially you learn how to handle your alcohol. You understand what it's like when you walk and you think and you make decisions when you're intoxicated. Not a great way to develop tolerance, but I think many people have seen that. This is what some people, including Taylor Swift, have called functional alcoholics. Right? It's this idea that you could be normal because you've learned how to handle your alcohol. There is such a thing as cross tolerance, where we treat people who use alcohol with a benzodiazepine, even though they're different medications. We don't treat alcohol withdrawal with alcohol. We can to some early extent. Alcohol users do it every day when they wake up and they have an E, right? A KG, an eye opener, right? They try to quell their alcohol withdrawal all by themselves. But once it cycles beyond that level, it's no longer going to be responsive to simple alcohol, and you need to use a cross-tolerant drug medication. And we'll usually choose a benzodiazepine, but many people are moving to barbiturates, and for the very, very sick patients in alcohol withdrawal, we routinely use drugs like propofol, which is a GABAergic agent, and it binds to the GABA receptor chloride channel in a mechanism that's very similar to benzos and barbs. So somewhat different, but similar enough. Now, opioid tolerance we think about graphically as the fact that you need more of a dose to get the same effect. So if you right shift the curves here, the dose response curves, you'll say that I need more drug to get the same response. Makes sense. And you'll say that you've decreased the efficacy of the opioid. Right? It no longer works. The drug is wearing off. But I will reframe that for you a little bit, and in a way that I think is so relevant to the opioid crisis that we experienced for the past 30 years in this country, and it's called hyperalgesia. Rather than the drug wearing off, it actually might just be that the pain threshold goes down, right? And OIH is a very important concept. There's a clear mechanism by which this occurs, but basically it takes less of a painful stimulus to have a given level of pain response. Regardless, to the outside observer and to the patient themselves, these are indistinguishable, right? Either way, whether you have to give more medication because the pain gets worse, or if you have to give more medication because the drug's wearing off, it's the same. But the underpinning of it are quite different. If you stop a drug in somebody who's tolerant, they will become normal. If you stop the drug in hyperalgesia, it does not go away, or if it does, it goes away very slowly. So physical dependence is obviously the development of a predictable withdrawal syndrome upon cessation or reduction in dose. And it typically improves upon restarting the drug. As I mentioned with alcohol, that can be a point of no return, where no longer does alcohol work to treat that, and you need to switch to a benzodiazepine. This can occur in dependence with quote unquote addictive and non-addictive drugs, caffeine being the best example. We routinely hear people saying that they're addicted to caffeine, but we recognize that addiction is not simply the development of dependence, right? There has to be compulsive use despite harm. And people that use caffeine, even to excess, are not going to do the things that people who use heroin or cocaine or some other truly addictive substance do. And it can occur with therapeutic use of medications such as clonidine. It's important to understand that physical dependence requires extended and significant exposure for the receptors to adapt. That might take days, right? So if a single use of fentanyl goes in your brain and out, it's not going to cause receptor adaptation. But if you bathe your brain in fentanyl for a long time, or alcohol, or anything, you will develop dependence. The receptors will adapt, and you will develop a withdrawal syndrome if it's a drug that's susceptible to withdrawal syndrome. With fentanyl, and why we're seeing such problems nowadays, is that single in and out dose works once. But if you keep doing that, it eventually, as I mentioned earlier, builds up in the adipose tissue and then leaches out over time. So even though that single use goes in and out the body for the most part, here the single use in and out into the fat, and then it repopulates the blood space, which repopulates the brain with fentanyl. So you can see here, after prolonged use in this one paper, you're still eliminating fentanyl and norfentanyl in the urine for 7 to 10 days after the last use. Right. And in that time, your brain is changing and adapting. So it's that prolonged exposure of the brain that leads to significant adaptive changes. The severity of withdrawal is also related to how quickly withdrawal develops. So if you allow abstinence to cause withdrawal, it's indolent and slow. It could be miserable, but it's generally pretty well tolerated, certainly with opioids. And alcohol, a little bit more concerning. But with opioids, comparing abstinence-related withdrawal to precipitated withdrawal, they're incomparable, right? Precipitated withdrawal is horrible. People have, strokes and MIs and pulmonary edema and hypertensive crises and things like that, because you go from essentially 0 to 60 in 2.8 seconds instead of over the period of several hours or days, like you would if you just allowed abstinence to occur. So the rate of the development of withdrawal, which only really affects opioids. I mean, we do have benzodiazepine antagonists, but I don't think we use those regularly enough to be an issue. But certainly the withdrawal associated with naloxone is concerning. Now, there's a million issues here about value and risk benefit, et cetera, but just understand the general concept is important here, that withdrawal severity is related to the rate of development of withdrawal. I want to talk a little about drug interactions, and these two examples are pharmacodynamic drug interactions, meaning it's how the drug affects the body. So people use heroin and cocaine because they adversely impact one another, right? This is the classical speedball, right? You can use more heroin because you have cocaine on board, which is keeping you awake. You use more cocaine because you have the heroin on board, which is kind of quelling the cocaine, right? So those two have a pharmacodynamic interaction. Alcohol and they go in opposite directions. Alcohol and benzodiazepines have a complementary, so to speak, interaction, but they're going in the same direction, which is why the combination of alcohol and barbs, or alcohol and benzo, is such a problem, because they're both sedating, they're both respiratory depressants, and they can lead, when in combination, to death. Another example that we see a lot of now is a drug like xylazine. Right. We don't really have a full picture of it, but we do know that xylazine is sedative. We know that opioids, fentanyl in most cases, are a sedative. So you would think that the two have an adverse interaction that would lead to a worse outcome. Most of the data today that we have does not show that, interestingly enough. Right. And there's a lot of questions about actually the outcome in people who use combinations, trank, so to speak, the combination of fentanyl and xylazine. So it's not at all clear that even though both sort of bring you in the same direction, they do it in a different enough way that they probably don't interact and lead to an increased risk of death. There are a lot of publications out there and there's a lot of messaging about the problems associated with the combination of these two products. The data does not currently support that, of course. And then there are pharmacokinetic interactions where the two drugs interact to change the metabolism, for example, of the drug. Or in the case of serotonergic drugs such as MDMA and an antidepressant, it leads to an increased release of serotonin to the point at which serotonin syndrome is something that might develop, which is muscle rigidity and altered mental status and hyperthermia, hyperreflexia, et cetera, that could be in and of itself life-threatening. Right. So this is not the change in the of two physiological entities, but rather the change in how drugs interact with receptors, the movement of the drugs around your body. Another key concept, and I like to remind people about this because it's also very big in the media, is that in toxicology and pharmacology, there needs to be an exposure pathway. This is somewhat equivalent to the route of administration that we talked about earlier. There have been a series of these police officer events in which police officers collapse after passive exposure to fentanyl. This is just one case that you can read in the newspaper from San Diego a few years ago, but there's many of these you'll read about. The implication is that the officer opens up the trunk or the car door and somehow breathes in or is exposed dermally to enough fentanyl to lead to a life-threatening response, and that just can't occur, right? It's just not physiologically possible. Just as an example to show you from the dermal absorption perspective, it takes days to get therapeutic levels with an application of a transdermal patch, right? So it's certainly not the powder falling on your skin is certainly not going to give you a therapeutic or a toxic level in any time more quickly than these patches, especially formulated to allow transdermal absorption. Nor is fentanyl volatile. The car doesn't fill up with fentanyl gas and then you open it up and breathe in it. Fentanyl does not work that way. The driver, him or herself, would be presumably affected as well. Okay, so I'm going to switch gears now and talk a little about drug testing and some of the issues that we think about when we talk about appropriate use of drug testing. You can find a lot of this information also in guides like from medical review officer tests or through medical review officers themselves. Now, remember, testing is not meant to catch patients, right? Testing is used to identify use so that you can talk to your patient about it, right? As the joke on the side applies, you're not using this as a tool to punish people. You're using it as a tool to support people, right? And language in these cases is very important, especially with drug testing. We think about using pejorative language like your urine is dirty, right? And I think people that are listening to this probably have a good sense of what that's about. There's two kinds of screening, two kinds of testing in general. There's screening and there's confirmation. Some people call it presumptive testing and definitive testing or confirmatory testing. There's lots of different words you can use here. But overall, screening test is a very highly sensitive test. It finds things, but it doesn't always find the right thing. It's pretty inexpensive. You can do it in your office. You can do it quickly in a lab. Often they give you cutoff levels. They don't give you specific numbers. Whereas with confirmatory testing, it is very specific. It sees what it sees, right? It's going to give you a specific answer with a number associated with that, how many milligrams per kilogram per liter or some equivalent unit. And the problem with them, of course, is that they're complicated, expensive, and they take a while to get done. Most of the screening tests that we do are immunoassay based. They look at the structure of a substance using an antibody or some equivalent directed against it. And again, they're easily automated, and because of this technology, it's not very different than, for example, a pregnancy test. They can give you a very quick answer. Analytical false positives are possible, right? So in other words, things can fool the antibody. So the amphetamine assay, as an example, will identify pseudoephedrine, or many other things, antidepressants that have a structure that's similar to an amphetamine. Right. So in people who test positive, if you need to know what they're using, in the emergency department where I work, we don't typically do that, right? But in some of your practices, you want to know what it is, and you will have to confirm them. Most of these screening tests will come back with a statement on them that says that this is a unconfirmed test. If you need to confirm it, you have to send it out for special testing, right? Analytical false negatives are uncommon. In other words, if you are looking for cocaine or morphine or something, and it's there, it will find it. They're very sensitive. The caveat, as I said earlier, is if it's positive, it doesn't mean it was what you think it was. It could be something else, right? So clinical false negatives occur, right? And a clinical false negative is really important because we see that a lot now if you don't know what you're testing for, because there's so many analogs out on the street. But for example, if you're using fentanyl, the opiate assay, and I don't like the word opiate, I like the word opioid, but opiate's right here because we are testing for morphine, which is an opiate, right? Only morphine and codeine are opiates. Everything else is an opioid. But the fentanyl molecule does not look at all like the morphine molecule. So here, just in a graphic description, you can see morphine here and an antibody against morphine. If you look like morphine and you're a morphinan, which is all of the structures that you currently see on the screen, it will find many of them. Some of them it will only find partially because you could see there's some similarity in structure, but it's imperfect. So you might need a higher concentration of hydrocodone, for example, for the antibody to trigger positive. And for oxycodone, you might need a higher level still. right? And for heroin, it might not find it at all, right? And we know it doesn't find heroin. We know it does find oxycodone at very high levels. And each of these tests differs a little bit. So I would recommend that wherever you work, you need to look at the profile of the test that you use in order to really understand its performance characteristics. But you could see that fentanyl and methadone have structural distinctions from the morphinan, and the antibody will not find them. Now, you can easily get an antibody against methadone and an antibody against fentanyl, but the standard opiate assay does not find them, and it will not find them almost regardless of the dose of those medications, the level, the concentration. Right. I'm not going to spend a lot of time on this. You can certainly read it at your leisure. But I do want to point out that some screens are very, quote unquote, promiscuous. They find a lot of things. Right. As I mentioned with amphetamines, anything with an amphetamine backbone, which is a common backbone to a lot of medications, will be detectable potentially. Whereas other screens are exceptionally good at finding only the thing they're looking for. Right? Cocaine looks for benzoylecgonine, BE. It doesn't find other local anesthetics because they do not get metabolized to BE. So you can't say it's a lidocaine cross sensitivity or mistake. It's if your cocaine assay is positive, you've used cocaine. Right. Now, you could have chewed coca leaf and not snorted cocaine, but that's a totally separate issue that analytical testing will not be able to figure out. It can only tell you that you have cocaine in your body, not where it came from. Now, I know this is often discussed, but just for the purposes of this discussion, you're evaluating a patient who tests positive for opiates on routine testing. The patient assures you they have not used any drugs. You go and you ask a lot of questions and they swear they haven't, but you dig a little deeper and you found that they've been eating poppy seed bagel. Right? Poppy seeds do have morphine in them, right? Tiny little concentrations, tiny little doses. But the test being positive is analytically correct. There is morphine in their body, but it's a clinical false positive because they weren't using heroin. To find heroin, you need to measure 6-monoacetylmorphine, which is measurable, right? All screens suffer these problems. Right. They also don't tell you which substance that they used, right? In this case, is it morphine? Is it heroin? Is it codeine? Because they all get metabolized to morphine. They don't correlate with impairment, and they can't tell you the route or time it was used, when it was used, the amount it was used, or anything like that. They have a lot of limitations. Now, a negative screen might mean that the patient's not using. Now, if this was a drug treatment program where you're expecting to find buprenorphine, for example, or methadone, and there's nothing there, it means they're not using it, right? For sure, because these screens are very good at finding things. As I said, they're very analytically sensitive. It means they're diverting it, they're not taking it, they're not going to their program, whatever it is, there's a reason, right? But there are clinical false negatives, right? In other words, they are using it, but we messed up the performance of the test. For example, there's a collection or a lab error. We sent the wrong patient's urine or blood. We used the wrong assay. We're looking for oxycodone, but we sent an opiate assay. You need an oxycodone assay because the cross-sensitivity of oxycodone with that assay is poor, except at very high oxycodone doses. And again, it varies among assays, so you have to look at the performance characteristics of your own test. Right? Cutoffs can be used, so you can get back a negative even though you have a positive concentration, but it's below the cutoff, right? And that's something to always consider. Or you could be out of the detection window, right? Remember that single dose of fentanyl might be present for 2 days, right? But if you check 5 days later, it's not going to be there. Cocaine, 3 days. You can see there how long these things last, and typically they last about 3 days. But the longer you wait, the lower the concentration that's going to be left in the body, and the more likely you are to have escaped the detection period. Or they can adulterate. And there's a whole, I left a slide for you to look at about adulteration, but there's a million ways people look at adulterating. It's way more than we could talk about here, whether it's dilution or they add chemicals, et cetera. And there's a lot to be thought about. Confirmation is done largely by one of 2 ways, GCMS or LC tandem mass spec. You can see that here, this is way more than we need to talk about, just to understand that you can confirm if you want to and get a very specific answer. It's really important nowadays, though, to do that because the array of drugs we find in our drug supply is vast and variable. And you can just see here over time in the benzodiazepine world just how many different benzodiazepines we've seen. Some cross-react with the benzodiazepine assay at low levels, some at mid-levels, some at high levels, some don't cross-react at all, right? And there's a lot of variability. And you can see that you would not really know what's going on with your patient if you just did a urine drug screen and you didn't do enhanced testing. Now, I don't know that you need this for most of your patients. It's expensive and difficult. Certainly from a research perspective and from other reasons to do it is a lot of value. Whether we need to do this regularly is a whole separate discussion that's not part of a pharmacology discussion. And then buprenorphine assays and analyses, again, it's a whole separate conversation, but you should just understand that you cannot say that if I give 10 people X amount of buprenorphine, they're going to have Y level, right? It's very difficult to predict. There's a lot of variability among people based both on their size and their metabolism and other things. But what you can generally say is that if I give patient X this amount of buprenorphine, their level should be Y, almost within a small range all the time, right? So trending testing can be helpful in a person, but it's not very applicable to a population, right? You know it's an adulterated specimen when there's buprenorphine without metabolite, right? There's no other way. It means they dipped their strip into the urine specimen before they turned it in, right? Bupes that are exceedingly high, even if they have metabolites, are also suspicious for adulteration. You can have higher bupe levels than norbupe levels, especially if you test shortly after dosing. Remember, norbupe is the metabolite and it lasts for a long time. So typically the ratio would support having more buprenorphine more norbuprenorphine than buprenorphine, right? Or there could be something that's slowing the conversion of bupe to norbupe, such as the 3A4 inhibitor. And there's many of those, and I'm not going to go over the list, but there's some in the chart I provided earlier, and you can look up these things. And then, of course, matrix considerations. What is the window of detection? How hard or easy is it to get these things? How easy is it to tamper? A whole separate discussion, which I left a little bit in the slide set for you. I'm going to end here and hopefully remind you that if you have questions, I'll provide you with my contact information at the end. But you can reach out to a medical or forensic toxicologist. We love talking about this stuff. I'm a medical toxicologist and addiction medicine specialist, and a forensic it's a physician who practices human poisoning, and a forensic toxicologist is somebody who does the analytics at the testing labs, and the staff at the testing labs is super helpful. And I mentioned earlier, people that are certified in MRO or medical review officer training are also great resources for this. Okay, question. What property of fentanyl accounts for its enhanced psychoactive effects compared to morphine? Is it charge, lipophilicity, molecular weight, or potency? Second question, I'll come back to the other question in a moment. A patient started on opioids requires increasing doses of medications to get adequate pain relief. At the same time, painful stimuli elicit more pain than they previously did. What does this represent? Is it hyperalgesia, pharmacodynamic tolerance, pharmacokinetic tolerance, or withdrawal? Okay, so the answer to the first question is lipophilicity, right? That's the key driver of fentanyl's euphoria and of its long-term complicating effects on induction, for example, or initiation of buprenorphine. And of course, this is a classical description of hyperalgesia, which I brought up earlier as a key driver of the opioid crisis. Which of the following screening tests is associated with the lowest rate of false positive results? Amphetamine, cocaine, opioids, or phencyclidine? And the answer is cocaine. Very little cross-reacts with the cocaine assay, unlike the others, which do have a significant number of cross-reacting substances. So as I mentioned, I will give you my contact information, and I'm happy to hear from anybody. Thank you.